we'll be kickstarting the day today with our pediatric session. And the first lecture will be on something which is very, very common and which is very, very enigmatic to all of us, which is lateral condyle fractures. And I'll be talking to you about the 10 tips of management of this difficult injury. Why is this fracture special? Because it's difficult to visualize, because there is intra-articular step involved. There's a physeal injury, chance of physeal injuries, and there's a chance of non-unions. And that's why this fracture is many a times missed, it is misdiagnosed and mistreated. So let's look at the 10 tips in order to prevent these 3 misses in fracture lateral condyle humerus fractures. So the first tip is we should know the anatomy well. What does that mean? So you see this small little faint fracture line, but this fracture line signifies that this is a very big fracture fragment, which is a non-ossified fracture fragment, which is cartilaginous. This is an intra-articular step, and we should also know that the common extensors are attached to this big fragment, and which is going to cause displacement over time. The second thing about anatomy we should remember is that the blood supply of the fragment comes from the posterior aspect, and hence whenever we have to dissect out, we have to dissect out anteriorly and not fiddle around posteriorly. The second tip is very important, which is to visualize with the correct positioning of the X-rays. Now this is a typical case. This was an X-ray which was shown to us. A 6-year-old boy, fall on outstretched hand, slab given elsewhere, and comes with his X-ray which has been reported as normal. There is a tenderness laterally, but we should get better X-rays without slab, and you can see that now there is a grossly displaced lateral condyle humerus fracture. It is important to know how to take a good elbow X-ray with a painful elbow. Remember, the child is going to come with a flexion deformity like this. And typically, the radiology technician is going to get an X-ray with the point of the elbow kept on the X-ray screen. So this is neither an AP of the distal humerus or neither an AP of the proximal radius. This should not be done. Similarly, if we keep the forearm flat on the X-ray tube, you will get an X-ray which is an AP of the proximal radius and not the distal humerus. So remember, you have to get a proper X-ray, which is an AP of the distal humerus, in order to properly visualize this fracture, which is like this. And then you also have to get a good internal rotation oblique X-ray, which will give rise to visualization of the displacement of this fracture. So remember about this tip. Second is investigate. Always remember that this small fracture may show that it is a big intra-articular step. And hence, you can either do an MRI or do an arthrogram, which will be intraoperative, which will prove that it is an intra-articular fracture, prove the reduction, and then, if required, you can do a fixation at the same time. You need to classify well. There are various classifications which show where the fracture exits, whether it is stable, and how displaced it is. And there are various classifications which we know. The Mirsky's classification shows where the fracture exits, where type 1 is it exits medial to the trochlea, type 2 it exits lateral, and type 3 where it exits medially. A Milch shows whether it is stable, where it is type 1 it is stable, and type 2 is an unstable injury. And similarly, the Jacobs classification shows whether it is undisplaced, minimally displaced, and completely displaced. But there is one classification which really guides treatment, and which is the Song's classification. Song has classified it into 5 stages, stage 1 to stage 5, in which you can say that stage 1 to 3 or 1 to 2 you should just conserve. Stage 3 and 4 you can do a conservative operative means, which is a closed reduction and percutaneous spinning, and stage 5 you should do open reduction. Thus, remember about these classifications and remember about the Song's classification. Tip 5 is about the conservative or a conservative operative, that is a closed reduction means of fractures, fixation. So you see this sort of small fracture, if you do an investigation of an MRI, you can see that it is not going towards the intra-articular region. You can conserve. As against that, you can see this fracture which is going into the intra-articular zone, in which case it is not going to heal, and that's why you should fix it. You can fix it with a single 1 or 2 wire as long as the arthrogram is showing a good reduction. Thus, tip 5, you should remember that you can conserve only after you investigate a lateral condyle humerus fracture. How do you manage the stage 3, 4, 5 injuries? You can see this big looking fracture fragment, You can see that the lateral displacement is much more than the medial one. You can do a close reduction as long as you are getting a good reduction. Confirm it with an arthrogram and only then accept this reduction. There are some people who can do a close reduction even in type 5 injury. I am not as skilled as them. But if in any doubt, remember, you should always open. Don't accept a close reduction unless you are absolutely confident that this is something which you are very, very confident that there is no intra-articular step here. My preferred means of open reduction is a simple lateral approach. It's a very quick method. You just reach the fracture fragment directly. You can just go into the supracondylar ridge. Remember, as I said, you should know the anatomy. Remember that the blood supply comes from the posterior aspect. So always have your dissection anteriorly in lateral condyle humerus fractures. I always like to put these pins like this, which are divergent bicortical pins. The next part of the lecture is on late presenters. Remember, late presenters, all of them are not the same. They have different avatars, and we can classify them as this movie, the good, bad, and the ugly. So you have this fracture, an 11-year-old male, history of trauma 5 years back, and has now come for just a bump on his elbow. You can see that he has fairly good alignment. He has fairly good, almost full range of motion. And this is a stable non-union. Here the 4 components, which are the deformity, is acceptable. The ulnar nerve is normal. There is no instability. And the range of motion is good. So this is a good non-union. You can just observe it. So whenever you get a non-union, you hope for a good non-union, which you can conserve. The next one is where you have a good range of motion, an acceptable deformity, no instability, with just a palsy. Remember, you can get an ulnar nerve palsy even without a gross deformity. In which case, you just treat what the problem is, which is by just doing an ulnar nerve transposition. So this is one type of bad non-union, but you can treat it with just a ulnar nerve transposition. The next situation is where there is a good range of motion, there is an acceptable deformity, there is no ulnar nerve palsy, but they come with symptoms of instability. Now this instability is sometimes very disabling. Sometimes when you press on your hand, they feel a bit quite unstable, in which case it is an unstable non-union. In which case, what you do is just an osteosynthesis in situ. Remember, you should not aim for intra-articular alignment. You should just aim for metaphyseal union, and that will lead to treatment of that instability. So that is something which is important. So if you have just instability with all other findings acceptable, you can just plan to fix the non-union. Last but not the least are these ugly non-unions. You have this patient, almost an adult patient, an 18-year-old boy, deformity which is very severe, fairly good range of motion, but with good significant amount of instability and with symptoms of ulnar nerve compression. So in which case you do a corrective osteotomy with or without an ulnar nerve transposition. You can see this sort of gross deformity, and this is how I do a corrective osteotomy. It is a metaphyseal corrective osteotomy. I remove a small triangular wedge in the proximal segment so that this achieves a good on-table stability, and I like to fix it with a small plate. And if the child is away from skeletal maturity or if there is instability, you fix the non-union along with it. So you can see this amount of excellent correction, and then the non-union eventually heals into a good fibrous union so that then the instability comes down. So these ugly non-unions, you treat it with a corrective osteotomy, ulnar nerve transposition, and you fix the non-union only when there is instability or if the child is away from skeletal maturity. Thus, these are the tips for conquering lateral condyle humerus fractures. Remember about the anatomy, about the common extensors and the blood supply. Visualize with correct positioning. Remember how to do a good X-ray of the lateral condyle with the distal humerus placed AP. Investigate with either an arthrogram or an MRI. Remember about the classifications, especially the song classification. Know about the close reduction methods of treatment, especially with arthrogram assistance. Know about how to do a good open reduction. A lateral approach is an excellent method for open reduction. When in doubt, fix. When in doubt, do an open reduction. and classify the late presenters into good, bad and ugly and treat them accordingly. Thank you very much.